autism is a developmental disorder, so it changes severely impaired. That child might actually improve dramatically over the next 3 to 6 years, and at 6 not be dramatically impaired. So maybe it's something like kids who don't show improvement over time, which there's a substantial portion of kids who don't do that. But I think that this general issue of how do you define a severely impaired individual with autism? If it's somebody who has good receptive language but no expressive language, is that a severe impairment, or is it somebody self-injurious? I mean, I think we need to develop some metrics to be able to answer that. But again, I want to just remind us all that you can't just take a slice of life. You have to look at the course of the individual's life over time.
Sorry, I want to give a moment, and I see Alice with her hand up, and I think given the fact that you've spoken on behalf of this organization, perhaps you might comment on what the organization is.
So I think that the idea here is that individuals with severe autism have different service needs than individuals whose autism enables them to participate at the policy-making table, or even enables them to be interested or able to look for and hold down a job. I mean, this is an organization that is seeking to bring a voice to the table of people whose number one goal is really to reduce self-injury, because that is incredibly debilitating in terms of any opportunity to participate meaningfully in the community, or even to just prevent physical injury. It's also necessary because, frankly, in the DSM-5, everyone was lumped together as having autism spectrum disorder. So the term autism spectrum disorder has now come to really be seen in the general media and by the general population as people who have very high-functioning autism, those people who are depicted in the media, who are on shows like The Good Doctor. People look at that and say, oh, that's autism, that's not so bad. Why do you need research? Why do you need to raise money? The higher-functioning individuals with autism spectrum disorder are, as I said, able to participate on the IAC, which is great. They are also the ones who are able to comment in the media when studies are published and give their opinion, whereas this particular segment of the autistic population is left behind because of the nature of their disability. And the purpose of this organization is to bring a voice to that group that has been left behind, because in many cases, they have the most severe medical needs, they have very intensive service needs, and we have to make sure that we remember them when we are talking about research, services, and policy. So that's why this group was formed.
Thank you. John, did you want to make another comment or question?
I would agree that we have to be mindful of autism in all of its forms, and I am always concerned in my own advocacy that because I am so clear and articulate in my speech that I create a false impression, and there are in fact many autistic people who are not blessed with that, and I wish that I knew a perfect answer to give voice and help to that.
So I wanted to answer the question, at least partially, that you posed about is severe autism and let's for now call it less severe, I don't know if that's the right way to put it, autism, are they the same thing? And I think we are getting some answers, at least from one domain, that help clarify the relationship. So in one sense, those with severe autism, and by here let me be very explicit, the data refer to those with intellectual disability in addition to social disability, that they have a higher preponderance of rare mutations in the genome that are with big effect sizes, right? So to some extent you might say, oh, that means it's somehow a different disorder. It's one that's caused by a different kind of mutation than individuals with less severe intellectual disability. On the other hand, though, when you look at those rare mutations, the bulk of the evidence would suggest that most of those rare mutations don't automatically give you a diagnosis of autism. That in order to have a diagnosis of autism, even if you have one of these rare mutations, you tend to have a higher load of common mutations, which are associated with all autism. So in other words, those with severe autism, or those who are in that severe end of the spectrum, have some genetic differences that set them apart, but also a significant, if not most, of their genetic liability that is in common with those with less severe forms. So just like the answer is that autism is on a spectrum, the notion that ends of that spectrum are the same is on a spectrum itself. And that's what makes it so thorny to figure out where is the dividing line. And let me tell you, as those around the table who do more than just work in autism know, this is true throughout the mental health spectrum. It's probably throughout the health spectrum, but doctors and other disciplines tend to ignore it or have better ways of classifying. But, we have the same issue with schizophrenia, with bipolar disorder, with dividing bipolar from schizophrenia. And in fact, globally, as our colleagues at SAMHSA will tell you, we have the same issue with deciding what severe mental illness means compared to the rest of mental illness. So I think these are common themes. We're talking about brain disorders that have tremendously complex multifactorial etiologies. Lewis, did you want to say something?
Yeah, I wanted to say, well, you can say there's certain mutations that have tremendous hits to function, which would automatically give you low function. In fact, it's a probability thing. There are many people that this has not been identified yet. And, one of the challenges is you say it's an under-researched population. Yeah.
Thank you. Are there other questions? Other oral comments? We've been focused on a couple of them.
I just say that the comments to the IACC about how we've been inadequate in terms of responding to the patients, I think I agree. I think we all agree, and we all feel really bad about it. So I just think that for people listening, I'm sure everybody around the table feels the same way, that we're as frustrated as anybody in the slow progress that we've been able to get at. So.
Okay, thank you. So it's now 2 o'clock. Our Department of Justice presentation is due to start at 2:15. I suggest that we take are they here right now? Yes, so why don't we take a 10-minute break and be back at 2:10 and try to start up then, so we can get ahead of the curve if there's more discussion on that. So we'll be back here 10 minutes after 2. Next up, we have a presentation from the Department of Justice on Kevin and Avante's Law and Disability Programs. And to introduce this presentation, we welcome our own Allison Singer, the president of the Autism Science Foundation and an IACC member, to introduce the panel.
Okay, so I am going to give just a brief 5-minute sort of historical look back at the issue of wandering as it relates to the IACC. In 2018, most recent year, we had 224 cases of autism. wandering. We are seeing more deaths among teenagers and adults who are wandering. Overall, I'd say we're seeing more training and better awareness about water risk, but there are still many agencies in rural areas particularly who are unaware of this particular phenomenon, and many agencies that continue to request training. So here's just a look at the timeline. Back in October of 2010, the issue of wandering was first brought to the attention of the IACC during public comments by Lori McElwain, the president of the National Autism Association, who will be on the panel today, I'm thrilled to say. And immediately we formed a safety subcommittee to investigate wandering, and that subcommittee was chaired by Lynn Redwood of Safe Minds and by myself. In the following month, a consortium was formed. The consortium members included the Autism Science Foundation, Autism Speaks, the Autism Research Institute, the Global Autism Collaboration, and the National Autism Association. And we immediately wrote and distributed a survey to study wandering utilizing the Interactive Autism Network. So it took us about 2 months to design that survey, and by March of 2011, the survey was released to the community. And it surveyed 1,218 parents of children who had ASD, and 1,076 of them also had non-affected siblings. At the same time, we also drafted a letter to then Secretary of Health and Human Services, Kathleen Sebelius, and the following month, March 2011, we received a letter back from Kathleen Sebelius thanking us for alerting her to this issue. I think this is a great example of urgency and of response to urgency, because 5 months after we released the survey, we presented preliminary data to the IAC about the problems of wandering. And what these data showed was that 49% of kids with autism spectrum disorder had attempted to elope at least one time after age 4, which was 4 times the rate of their unaffected siblings. We used unaffected siblings as our control because we didn't want to have an issue of this being the result of bad parenting. So the idea was, if you were a bad parent, your non-autistic child would be just as likely to wander off because of neglect than your autistic child. 53% of the kids who eloped were missing long enough to cause concern. Also, I want to point out that from age 8 to 11, 27% of children who were diagnosed with autism spectrum disorder eloped, compared to only 1% of the unaffected siblings. I also want to point out that I always think this data looks like a shoe, sort of, for wandering. Okay. 6 months later, just 6 months from the launch of the presentation by the National Autism Association, the CDC had already worked to get an ICD-9 medical subclassification code for wandering. And this was another way for us to get better data on the extent of wandering, because now we had a medical code where doctors would be able to make a notation in medical records. So thank you again to the CDC for those efforts. In May of 2012, the data from the wandering study were presented at the International Meeting for Autism Research. And in October of 2012, those data were published in Pediatrics. And this study was later included in the 2012 IAC Summary of Advances of one of the key studies in that year. The study, when it was published in Pediatrics, got a tremendous amount of press coverage, including USA Today, US News and World Report, the New York Times, ABC News, and Good Morning America. But despite that, parents were still reporting that they were not receiving any anticipatory guidance from their healthcare providers. Over 50% said they had not heard from their pediatrician that wandering was a risk related to autism. And these data are also from the Interactive Autism Network. So, in response, the Safety Subcommittee reached out to the American Academy of Pediatrics, which is an organization that represents 65,000 pediatricians. And the CDC, again, worked with the American Academy of Pediatrics to develop these fact sheets about wandering to be included in the American Academy of Pediatrics toolkit. These fact sheets were designed for parents
limited when we don't have the proper funding. So that's why we need Kevin Avante's law to be appropriated and for us to get that funding. Prevention is essential. These are some of the survey results from our Big Red Safety Box recipients. And we'll get emails and comments from parents saying, just that door alarm saved my child's life because he got out and he was heading towards the road, but because I heard it, I was able to get him, before he could really get away. So we get a lot of that, and it's not that hard, these little door alarms, and giving them out. And we also do it for schools as well. Project Lifesaver is another radio frequency, not GPS, but radio frequency trackers. It's more reliable and run through law enforcement agencies. And so if the child does get out, if the child is missing, this is sort of the gold standard. In Annex's case, a lot of people wanted these tracking devices, but a lot of times they're just not available. If they are available, some still have age exclusion. So this was a case out of Michigan. A mother had called. She had lost her son to drowning. He had autism. His brother also had autism, and she wanted to get a tracking device for her other son. But there was an age exclusion. They had to be 60 or older, right? Now, this county worked with me, but it jumped through some hoops to make that happen. And that should be happening. It should be open for everybody. IACP, love this initiative. It'd be great to have something similar for autism. 40,000 members getting training, getting collateral pieces, do's and don'ts. Just search water first. Just that one little tip. 40,000 members. It's easy. We can do this tomorrow, right? It's easy. But IACP needs the funding. So, once again, we need to get that appropriated. Still an urgent issue. There's less notifications to NCMEC, but there are more cases overall. That's because the ages are going up. There's major differences in Alzheimer's versus autism. Similar resources are needed. There's an increase in average age of leave of cases, more agencies requesting interaction training especially, and this mental health or comorbidity is adding complexity to this issue, and we really need to talk about that and the unique hidden challenges that these children face. So risk contribution. I think 56% have intellectual disability or borderline intellectual disability. And then there's how many who are nonverbal, 25% to 40%. That contributes to risk. And then wandering, 50%, that contributes to risk. And suicidality, so 9 times, Sarah Cassidy is doing great work on that. That contributes to risk. So we're really looking at risk here, and that's what I feel like is being underrepresented. And that's where having that voice comes in. Because there's so many hidden challenges, and families like mine, where we have to live apart. We have to live apart to keep our kids safe, right? And you don't hear about these challenges because we don't talk about them. We're not here. We're in survival mode. But this is a good place to talk about that and to get families like mine represented on this committee so that we can really look at those risk factors and make those a priority. It's not about high, low. It's about risk. And right now, there's a lot of risk out there. A lot of families going through some complicated issues, and they're not represented. So. Thank you very much. Oh, backwards. Okay. Good afternoon. My name is Maria Fryer, and I'm the policy advisor at the Department of Justice Bureau of Justice Assistance, and I oversee the justice and mental health portfolio. I'm here today to just talk about some of our initiatives and some of the work that I've been engaged with over the last 4+ years at BJA, and hopefully just kind of laying some groundwork for some of the things that we've been involved with and sparking some interest in looking at some of these programs and initiatives as sort of foundational to moving forward with additional programming and addressing the needs of vulnerable populations. So today's discussion is basically here, just an overview of what I'd like to cover. So BJA, just to begin a little bit about the organization, the Bureau of Justice Assistance supports, like I mentioned, many initiatives and programs that help communities address their state, county, local, and tribal responses to people with mental illness and intellectual and developmental disabilities. And I hope you forgive me, I'm going to stick to my notes because of the time frame. I know we have a certain amount of time to get through a lot of material, and I won't freewheel it because I'm trying to make sure that I impart some of the programs that we've got. So bear with me on the notes. But my hope today is basically to, going forward, to just share our programs and initiatives and services with all of you, and to start by learning from you. And I'm so grateful for the presentations today and being able to take all that in and gather that information, especially the work that's been done thus far, and also seeing BJA as funding some of the initiatives already through ICP. So that was very encouraging. We've had similar but different experiences with vulnerable populations, so it's up to me now to gather what's been done to date in the justice system, know what's been done well, what needs work, and know where the gaps are and how we need to be effective moving forward. So the next
and we'll miss her, but we're very pleased to have Ms. Williams. Ms. Williams, would you like to just introduce yourself briefly? Tell us a bit about yourself.
Good morning. I'm Cheryl Williams. I'm the Director of the Office of Medical Policy within the Office of Disability Policy of the Social Security Administration. I've been in my current
take care of the minutes, and so it helps to speak clearly to the microphones. With that, I'm going to turn the mic over to Susan Daniels, and who's going to do the roll call and the minutes.
Thank you. Good morning. So I'll take the roll call for the IACC. So first on my list, Joshua Gordon.
Here.
Judith Cooper.
Yes, good morning.
Alice Cow.
Here.
For Linda Birnbaum. Cindy Lawler.
Yes, I'm here.
For Linda Birnbaum and Al for Diana Bianchi. Carrie Wollenetz. Yes, here. For Mrs. Collins. Elaine Hubel. Tiffany Farchione is not able to join us today from FDA. Melissa Harris.
Here.
Jennifer Johnson. And I think Jennifer has an alternate, may not be here yet. Laura Kavanaugh.
Here.
Someone for NINDS for Walter Koroshetz. Not here yet. Laura Pincock.
Here. Good morning.
Morning. Marcy Broniak is not able to join us from the Indian Health Service. Stuart Shapira.
Here.
Melissa Spencer. Or Cheryl Williams.
Good morning. Not here.
Christy Kavulich for Wexler.
Here.
Nicole Williams. David Amaral.
Here.
Jim Ball. Samantha Crane. Jerry Dawson.
Here.
And David Mandel is not able to join us today. Kevin Pelfrey.
Here.
Edlin Pena. Louis Reichart.
Here.
Rob Ring. John Robison.
Here.
Susan Sitter.
Here.